complication in your practice?
If you're talking about complications from the standpoint of fat transfer, we're very fortunate. Fat transfer itself doesn't carry with it a whole lot of risk of complications. But I always remind patients that you are moving cells from one location to another. Some of those cells may not make it. If we're talking about the breast, then you can still have a breast lump, butt mass, cyst. You can have a ductal obstruction. You can have a calcification. You can have the scarring of fat necrosis where those cells, the scarring of fat necrosis where cells don't make it. In most of the patients that haven't had a prior surgery, it's a very low incidence of any of those things. For patients who have had prior surgery and multiple surgeries, then risks increase in regards to the unpredictability of whether those things are going to occur.
Somebody asked, can one breast end up bigger than the other if the fat retention differs in each breast?
It's rare that would happen. The way that you partition off the fatty tissues you're taking it is also important, because these ratios of the cells I was talking to you about can be different from, say, one part of the body to the other. So when we go to harvesting something, what my nurses are doing is that they're basically in that centrifugation process, we take it off, and when we distribute it, we make sure that we're splitting the areas evenly, so that basically we're applying the same and similar ratios of cells to each breast. And in that way we can avoid differences, as I said, in cell numbers, cell counts, that survival, the viability of the different types of cells in that process. Now, there are patients who have asymmetries to start with, and we can try and make up for them, but we can't always make up for them in a single session. So keep in mind that we may be trying to put more in a particular area to make up, but that doesn't mean we can make up for all of it. And as far as retention goes, I know patients say, "Well, have you ever gotten to a point where you've never had anybody, retain anything?" No, we've not had that issue. It's not that it couldn't happen; it's just not an issue for us. And I think that patients' post-operative care has a lot to do with it. Our patients are usually very, very good about just following a very minimal basic instruction. That is, don't sleep on the chest or breast for 3 months. Abstain from alcohol and smoking for the 3 months. If you're exercising, just don't train like you're training for a marathon, a triathlon. The cells are fragile for the first several months. And those cells being fragile like that, if you take good care of them, they'll ensure that permanence, and you don't have to worry about it. But I would tell you that there's no doubt, I think that there's been a number of patients who were smokers. They did quit smoking, but post-operatively, I don't think they could get through that period. It's a very difficult thing to do, we know that. But you could see, if they went back to smoking, that their retention was a little bit less.
Here, how long would you want to wait between, let's say, en bloc explant and then do fat transfers? In 3 months minimum, 4 months?
It's, in 4 to 6 months. We've done a number of patients, I was waiting at 6 months, and then there were some patients that were just asking, can we try a little bit earlier? I did find that up to about 4 months, it seems like we can achieve same and similar, and we're not dealing too much with the hardness, the firmness of the scar. At least it's gotten to a point that it's manageable. And I know that a number of other surgeons are kind of in that ballpark. So I would tell you that, that implant removal, en bloc removal, 4 to 6 months, and everybody's going to be different. Keep in mind, each and every one of you are different. And so your healing process and the way that you scar, it's just going to have to be a judgment thing. You're going to kind of know how well you're doing.
Okay. And can you breastfeed after fat transfer?
There's no reason why you can't breastfeed after fat transfer. The whole idea behind the fat transfer is I was talking about a blunt tip cannula. And that blunt tip cannula is being pushed between existing cells. Now, it doesn't mean that there's some cells that get damaged and some bruising that occurs, but the idea is not to disrupt anything. So a lot of patients who are ideal body weight and even below ideal body weight, I can do a patient up to about 10 pounds below ideal body weight, and I think I can make, it seems we've been able to make enough of a difference that they feel it's of value to them. But the sculpting side of this is an important part, and that subtractive sculpting I was talking about, now a particular approach being a little bit different than an additive, this thing. You can't avoid it entirely, but I may end up with a few little irregularities here and there in a thin patient, but again, as a percentage, and and as an ability to kind of like feather an area, even if it did occur. I mean, it's kind of a local kind of procedure, more common. So you can unroof certain aspects. Every patient being different, there'll be certain fascial compartments and bands that, as I said, that old textural difference, the fibrous difference, even as careful as you can be and all the experience you've got, you may not be able to avoid it. But it's a very, very low percentage, as I said, and I think a lot of you have been exposed to patients in some of the other forms that you can see that we basically are trying to refine figure as much as possible, maintain refinement of figure as much as possible. It's all in that process.